Richard Buckley here, Milford, MD. Usually you see me gowned and maybe with some kind of optics on and in the middle of a procedure. Some people don't like seeing procedures. So I thought we'd just talk a bit this morning. I will have the camera go to our patient. Today's procedure is going to be all about the upper and lower eyelids. When we look at the eyelids, it's nice to start actually above the eyelids and ask what's going on with the forehead. You know, very commonly there is some drooping or sagging because of gravity, and so it makes for some heaviness here, and then that adds to the appearance of, or the actuality of, the looseness of skin on the upper lid. If you look at this loose skin on the upper lid, and if I raise the eyebrow up a bit, you can see that does help a bit. It doesn't get rid of all the looseness, but it helps a bit. And so sometimes we actually do make a little incision up here, and commensurate with, or maybe at a different time, we do a little bit of a forehead lift, also known as a brow lift. The kind we do is a lateral subcutaneous temporal brow lift, most commonly. So about the lids today. Today we're going to trim the upper eyelids, trim the lower eyelids, and also tighten the lower lid margin. Let me explain that just a little bit. Can you close your eyes for us? Thank you. And so there's a little crease, it's known as the sulcus on the upper eyelid. Slightly above that is where the bottom of our incision is placed for the upper eyelid. You can open your eyelids now. And there's this extra skin here. And you can see the skin is hanging all the way to our patient's eyelashes, so she really doesn't have much place to put any makeup on there that would show, because the skin is draped over it. You can, I think, see how it drapes over it. So we're going to take off an appropriate amount of skin. And you don't want to just grab, you know, an armful and then take it off. It's in fact more important what you leave than what you take. And so we need to measure from the hair of the eyebrow here down a bit and leave, let's say 10 millimeters, and then we need another 10 millimeters somewhere. So if we have, let's say, from the crease to the margin of the lid where the lashes are, if we have 9 millimeters in the middle on the bottom, then we need 11 above. In other words, the total of whatever skin's remaining on the top plus whatever skin is directly on the lid here, that wants to be, I would say, at least 20. Now, there are differences in sizes of eyes, eye sockets, eyelids, and so we need to take that all into consideration. But suffice it to say, I need to mark things out very carefully on both lids, which are different. If you look, you'll see there's a difference between this lid and that lid. Quite a bit of difference. And if one gets into it, there's often a whole lot of difference, and we need to take that into consideration and try to bring about some symmetry and youthfulness. That's about the upper eyelids. The lower eyelids, we like to distract the lid a little bit and see how it snaps back. There's a pretty good distraction test here, or I can pull the lid out a little bit and see if it snaps back. It actually made a little snap. I don't know if you heard that, but a little, yeah, a little snap. That's pretty good. So your trampoline on the lower lid there is pretty tight, so I like that. However, we can see that this droops off a little bit to the outer part here, the lateral part. And what I would like to do is tighten that just a little bit. And so if we give a little tightening, which is known as a canthopexy, so we're going to do a lateral canthopexy today, that'll make sure that this lid is nice and tight when we're done with it. One of the reasons to do that is if we're going to start taking some of the skin out, as we are, then it puts a little more downward force on that lower lid, and we don't want it to be drooping down like that when we're done. So we're going to tighten that up with a lateral canthopexy, which means to tighten that with a little stitch in there. We'll make a little incision on the lower eyelid, and then we will trim some skin off, about that much. So I just pinch the skin. This is called a pinch blepharoplasty. Is again, you don't just pinch everything you can, and in fact the idea is to be conservative. One could always come back and take some more skin some other day if one wanted to, but you can't really put it back, so you don't want to ever overdo things. There also are some fat pads in there, which we're not dealing with today. There's a little bit of some bulging there, maybe something to do someday. And if you look carefully, you can see even if I tighten this, there's a little bit of some bulge there. But if we trim the upper lids and trim the lower lids and tighten the lid here, that'll be pretty nice. There's also a muscle that goes around the eye, which is a sphincter muscle, the orbicularis oculi, and it kind of has, you know, 3 different little bands. One of them is up here close to the lash, and that part of the lid is the tarsal part, so that orbicularis oculi muscle in that part of the lid right there is the pre-tarsal part. It's in front of the tarsus. Down below there, sort of where that bulge is, but down deeper, is known as the septal area, and so the orbicularis bundle that's there is called the preseptal orbicularis oculi, and then this is the bony orbit, so it's the orbital part of the orbicularis oculi, a circular sphincter muscle that kind of has 3 different components to it. Sometimes people get bulging in here, festoons. There's maybe a tiny little festoon there, but not too much. The pinch will help with it a little bit, and then sometimes we do CO2 lasering over the entire area to get some more tightening of the skin. In brief, that's what we're up to this morning: an upper eyelid blepharoplasty, a lower eyelid pinch blepharoplasty, and a lateral canthopexy, or tightening of the lower lid, which is different from a canthoplasty or a tarsalplasty. Those are different things. All right, so I don't know if we'll show you something later. It would have to be procedural because we're going to get to work now. Thank you for watching another episode of Milford, MD.